Hello everyone, let's start our today's head neck anatomy class. Now, we will be talking about all the important structures of your head neck and the questions that will come in your exam from this area. Now, these the things I show you are only the important ones. I will tell you all the important things you will have in your exam, and I will leave all the unimportant things that you will not have in the exam and that will unnecessarily cloud your mind. Okay, so what do? You stay mute and you watch the class and take our book and take some notes. See very carefully the structures I show you. That's how you can remember better. You will be able to remember better if you pay attention to the structures. See, not every structure is important. uh, in fact, sometimes you will see, uh, and remember one thing, that this is surgical anatomy. This is surgical anatomy, and there is a fine line. There is a beautiful fine line in between surgical anatomy and basic anatomy or anatomy. Why? You will not have a lot of basics questions from here. You will have a scenario and then you will have questions from there. That's why you need to know some structures very good, and you just don't need some of the structures at all. You will not need those structures at all. See, let's see what are the important things you will be facing. Let me just we don't need these markings, we will just remove these. Give me a minute. See, you have a lot of time, guys. 6 months is a very long time, and you don't worry about it at all. Anatomy is big. Remember, whenever you study head neck, focus on head neck only on head neck. Forget what you have studied in neuroanatomy. Like, what is past, because remember, whatever you have studied, your mind will remember that. All you have to do is to revise, and we have revision later on. Don't worry about those at all. So when you study head neck, study it like you will not have time in future 6 months to study it again, like you are studying it for the last time. Study head neck like you are studying head neck for the last time. Whatever in front, whatever behind, just forget all of those. Just focus on this very clearly. This is platysma. Just see. They don't ask any questions. Some just from where it is derived from. Simple. And we have a very beautiful short video about pharyngeal arch, pouch, and cleft. We will share that, and you will be able to remember it for your life. You will never forget it. And you will have 3 to 4 questions in every exam from only pharyngeal arch, pouch, and cleft. Only pharyngeal arch, pouch, and cleft. You will have questions minimum two, and maximum four. Okay, I know it all. Don't worry about it. Whatever I say is truth for MRCS Part A. Whatever I say is truth, and follow that. Guys, see, what are the things? Triangle. All our life we have studied triangles, but triangles here is not important at all. They don't ask you the boundaries. They don't ask you anything about the muscles or anything. Just remember what I say and remember those very carefully. After that, if you want to expand your knowledge, you can do that. But whatever I tell you, those are most important, and you must remember those. See, this is the imaginary midline, this is our anterior triangles, and this is our posterior triangle. Very simple and easy. Very simple and easy. From, if I show you from side, it will be easier. Very simple and easy. Now, in anterior triangle, we have 3 triangles. Only one of them is important. Only one. And what is important from that? Only one, and that is carotid triangle. What is important? Boundary? No. Boundary is not important. Important thing is the contents of carotid sheath. The contents of carotid sheath. They will not ask you directly that what are the contents of carotid sheath. That's a child's question, and you are not a child. That's why they will not ask you that question. They will ask you that you are a surgeon and you are facing a very difficult carotid end arterectomy, and during that carotid end arterectomy you injure a structure posteriorly and medially from internal jugular vein. What is that structure? So that is a question of carotid sheath. So that's how they ask you questions. Let me show you what is the structure. Let me add the arteries. Let me add the veins. Should remove the superficial ones. Then let's add the nerves. Okay, just some. This is sternocleidomastoid. We all know. We hide it. Now this is the carotid sheath. This is our carotid sheath. And see it very carefully. This is the sheath. I have not removed the sheath yet, but you can see inside the sheath. Inside the sheath, we have internal jugular vein. We have internal jugular vein. We can just see. We have internal jugular vein. Then we have, let me show you, internal jugular vein. We have vagus inside it, that is posteriorly and slightly medially. And we have internal carotid artery. Okay. And posteriorly and laterally we have vagus. So you have to know this relation. And when you see this relation from me, you will never forget it. And specifically, I will tell you specifically what are the questions they are going to ask. So inside the carotid sheath, you must remember that inside the sheath, vagus nerve is the most posterior structure. We have all in our notes written in our drive and in our books too, as drives are updated very frequently. Whenever I get time, that can be every 2 days, 3 days, 2 months, 1 month, I just update it. But books needs to be published. So books are a little bit late. But books have everything. Slight change, you just pick it up from our classes. Simple as that. Now, so I'm removing the sheath and I'll be showing you this is our vagus nerve. This is our vagus nerve. This is all these things are in carotid triangle. Now, then second question, they will ask you are doing a carotid endarterectomy, and what is the nerve you injured? What is the nerve most commonly injured? Remember, hypoglossal nerve. Why? See, look at its position, guys. Look at its position. You don't even have to enter carotid sheath. It's above carotid sheath and it's running like that. So if you do a carotid end arterectomy, most commonly injured nerve will be hypoglossal nerve because of its position. Look at its position. Most commonly injured nerve, this one, hypoglossal nerve. Second, vagus. Remember, this is the exam of best answer. Best answer. Third, glossopharyngeal can also be injured, guys. So, see, let's say you have an option A, that is phrenic nerve. Option B, you have spinal accessory nerve. Option C, you have glossopharyngeal nerve. Option D, you have some other nerve. Let's say just write other. But no hypoglossal in option. No vagus in option. But the question is, which of the following nerve can get injured during carotid end arterectomy? So among all these, only glossopharyngeal can be injured. So if you say that bhaiya, you have told that hypoglossal is the most common. Yes, hypoglossal is the most common, but they didn't ask that. and hypoglossal is not an option. You have to choose the best option from given one, the best one. Then second question, let's say they will say you are doing carotid end arterectomy, and which nerve can get injured? They didn't mention most common. They just said which nerve can get injured. See, let's say they gave hypoglossal nerve. Number 2, they gave vagus. Number 3, they gave glossopharyngeal. Number 4, spinal accessory. See, all these three can get injured. All three. But you have to choose the single best. So, which one you will go for? You will go for the most common one, hypoglossal nerve. That's the most common. That means all three can get injured, but this is the best choice from all three because this is the most common one. So, why people fail in this exam? People fail in this exam because they don't know. No, people fail because they know too much. They just know too much and they can't select the best one. Which one is the best? They know everything. You don't need to know everything, guys, to pass an exam, to save a patient. To save a patient, you don't need to know everything. All you need to know is how to save that patient, how to save that particular patient. So if you are a surgeon, there are people who will cure HIV, but you can't do that, right? And you don't know everything. So you leave that. You don't need to know everything, but you have to know your thing the best. Like everyone talks about saturation, guys. This is saturated, that is saturated, bro. Let me tell you one thing. Look at MRCS field. Wasn't it saturated? Aren't there a lot of coachings and all of these things? Still I started, and still people are getting enrolled. Like from all these coachings, people are coming to me. A lot of people, like people even don't get candidates with very low fees, and I get a lot of candidates, and 52 candidates just passed. Most people don't even have that much candidates in their coaching. What's the reason, guys? Saturation is a myth. Saturation is a myth. Saturation is a myth. I will tell you 3 times. Saturation is a myth. Guys, don't fall for this trap. You have a unique set of skills which you bring into this world. You have a very unique set of skills, and you are a doctor. You have a very unique set of skills. Don't be average. Use those skills. Use those skills and be different. Be so different that you become irreplaceable. Irreplaceable. You have to become different. Like you have to be very skillful in your work. So no matter how saturated the market is, you will always have your place. No matter which part in this world you go, if you have that thing inside you, if you have the faith that I can do better, I can do better, then you will be able to do it. And you will get everything, every single thing in this world, you will get it. So just leave all these Facebook groups, all these like in Bangladesh we have platform and these group, that group, we don't have job. Bro, we don't even have job in Bangladesh, and we get paid 20,000. Seriously? And you are complaining about UK or Singapore? Like why, man? Like look at our lifestyle index, look at our internet speed, guys. Like, is this a life to live? No. Look at the traffic jam, guys. What is happening, guys? Look at the traffic jam. Like if you are on a duty and you do a 12-hour shift, you get paid 35, 36, and how much time you give your family, how much time you sleep. Is this a life? And you are complaining that UK, we are not having jobs. This place saturated, that place saturated. Let's talk about Deshi degrees, anesthesiology saturated, surgery saturated. Bro, just forget all these people. Just forget all these people. These are negative people and they just ruin your mentality. Just leave them and do your work. Do your work very good. Do your work very good and you will always have your place. Okay, guys, a lot of things. I have told you a lot of things. Leave it now. We are getting back to our studies. So from anterior triangle, you need to know just carotid triangle. This one is very important, and less important is this one. This one. Let's add submandibular gland. Let's add submandibular gland. All you need to know. This is our submandibular gland. So it will be in our submandibular triangle. I will remove this bone and I will show you that submandibular gland is behind facial artery. See, this is very beautiful, right? Beautiful facial artery is running above it. So be very careful. And I will tell you which one bleeds very commonly, but see it. And this beautiful muscle, which is cutting the submandibular gland into two half. See, let me show you. See, very beautifully, like a sword. It's cutting this submandibular gland into two half. This half, and we have mylohyoid here. So remember, mylohyoid is facial diaphragm. Mylohyoid is facial diaphragm, and it prevents infection to spread from oral cavity to neck. So this piece of information is very important. Write it down. Then muscular triangle. Guys, they will never ask you the boundaries, but remember all the visceras in our neck, all the visceras. What are the visceras we have in our neck? Important ones. Let me tell you about the important ones. Larynx. Okay, larynx, then trachea. Let me add those. Okay, thyroid gland, then pharynx and esophagus, digestive. Okay, all of these are situated in muscular triangle. Now, will they ask these? No, they will not ask you this. They will ask you a very important question. Every year they ask it. That is tracheostomy. Tracheostomy. They will ask you two questions from here. From tracheostomy, one is emergency tracheostomy and one is only tracheostomy. When they mention emergency or they say there is an RTA and you need to do the person has airway difficulty and you are at the place of accident, what do? Of course, you do emergency tracheostomy because because you are at emergency site. And in hospital you will understand the scenario. We have examples in our notes. I will tell you. In hospital we will do tracheostomy. Okay, like why am I saying like that? Because these are the words they will use in your exam. They will only tell you tracheostomy in a hospital setting. Okay, let's talk about emergency first. Most of the time they will give you emergency. So in emergency cases we just pierce this cricothyroid membrane. We pierce cricothyroid membrane during during emergency. We pierce cricothyroid membrane. So that is called cricothyroidotomy 2. Okay, that is called cricothyroidotomy 2. So this is our cricothyroid ligament, and we pierce it. We pierce it like in the movies, guys. You have seen in Tamil movies, in English movies, like Vijay Thalapathy was traveling to an airport in a Tamil movie, and one person and the good doctor. If you have seen that series, The Good Doctor, you have seen emergency tracheostomy with a pen, with a pen. And how do you find the site? They will ask you the question. How do you find the site? Guys, see, they will just tell you that we just go 1 centimeter below thyroid cartilage. Okay, we just go 1 centimeter below thyroid cartilage. Simple as that. We just go 1 centimeter below thyroid cartilage. Okay, and then second option, like all of these are true. All of these are true. 1 centimeter below thyroid cartilage or midway between sternal notch and thyroid cartilage. You can do it here. Okay, this is midway. Okay, or what? Midway between cricoid cartilage, a little bit above, and cricoid cartilage, guys. No, midway between cricoid and sternal notch. This works too. Why? Why? Because because 2, 3, 4 makes the isthmus floor. This is our thyroid gland. This is our isthmus, and this is our two lobes of thyroid gland. And we pierce this isthmus during tracheostomy at hospital. Tracheostomy at hospital, we pierce that isthmus, and our usual site is midway between sternal notch and thyroid cartilage. But if thyroid cartilage is not mentioned, you can go for cricoid cartilage too. Simple as that. So this is a must have question in your exam, and you will have this question. Then let's talk about posterior triangle, guys. All these are the only things you need to know. Other than that, nothing is important. Posterior triangle, they will ask you about the boundary of posterior triangle. Anteriorly, sternocleidomastoid, posterior border of sternocleidomastoid, and posteriorly trapezius. Very simple. And remember, we have only one nerve here. Any question from posterior triangle, any lump excision from posterior triangle, anything in posterior triangle, any question, if the question is about nerve or a structure, that is answer is spinal accessory. Anything that comes from posterior triangle, you will have spinal accessory as the answer every single time. Every single time in your MRCS Part-A exam, you will have spinal accessory as an answer. Why? Because spinal accessory is a nerve that is very frequently injured, and they always ask from here. They always ask questions from here, only here. then then I will show you another thing that is very important. I'll remove the clavicle, and remember, middle third of clavicle, if we divide it into three parts, this is the second, this is the first part, second part, and third part. That is, this is the middle third of clavicle. Now remember, they will ask you questions from middle third of clavicle. A fracture in the middle third of clavicle, which structure will get injured? Okay, let's say we have a fracture here. Okay, and let's remove clavicle. Let's see what we get. See, guys, under the clavicle, first thing we get is this one, that is subclavian vein. Okay, under the clavicle, so subclavian vein. Then we have scalene anterior. Scalene, let's see, it looks like a scale. Then we have scalenus anterior. Then we have this artery. So all these structures can get injured, and behind that artery we have brachial plexus too. Simple as that. So all of these structures can get injured. All of them can get injured. Now, how will they ask you question? Which one is the first structure to get injured? This one is the first one. Very simple. So first structure to get injured will be subclavian vein. Simple as that. And if they don't give you subclavian vein in your option, which one is the next best? Subclavian artery. Simple as that. Subclavian artery will be injured. Very simple. Now, in between these two, we have scalenus anterior. We have scalenus anterior. Watch very closely and very carefully. We have scalenus anterior in between these two. Now, I'll be removing this thing, and you can see very carefully that a beautiful nerve is over. Wait, this is inside carotid sheath. Where is it? Let's just remove that. Okay, we have to add more nerves to see that. Okay, right now, don't get confused. See, this one, a beautiful nerve that is over our scalenus anterior and in between subclavian artery and subclavian vein. Okay, of course, remember right and left, both same, right and left same. So don't get confused about it. Now, see, in over subscalenus anterior belly, we have a nerve. All these nerve you see, these are above some other muscles. We have removed those muscles. That's why these are looking like this. If we add those muscles, you will see these are above those muscles. See, see, these are the nerves. This is our sternocleidomastoid, and this one is our phrenic nerve. This one is our phrenic nerve. Why am I showing you very importantly? Like, why am I giving importance so much in this phrenic nerve? Because they will ask you phrenic nerve question from various angles, from every single angle they will ask you question from phrenic nerve. How? They will ask you what's the nerve that lies over scalenus anterior belly and in between subclavian vein and subclavian artery. That is phrenic nerve. That is phrenic nerve. Why not vagus? We have seen vagus here because it's inside the sheath, it's not directly over its belly. Okay, okay. And if phrenic nerve is not there, of course, Vegas can be the answer because you have to choose the nearest one. Simple as that. So then I will show you another thing, the course of phrenic nerve. What will I do? I'll be removing brachiocephalic vein and you will see that phrenic nerve is entering the thorax. Phrenic nerve is entering the thorax, and the moment it enters, what is the structure I have removed? What's the structure I have removed? Guys, this one, here we had brachiocephalic vein. Okay, so when phrenic nerve enters the thorax, brachiocephalic vein is immediately medially to phrenic nerve. Immediately medially. So this is a very important question. They will ask you this question in your exam. Okay, see, this is our brachiocephalic vein, and phrenic nerve is just lateral to brachiocephalic vein, and brachiocephalic vein is just medial to phrenic nerve. So this is a very, very important thing to know. We hide it. So see, and so this is the entrance. BCV is medial. When it enters, you have to know very precisely. When it enters, brachiocephalic vein is medially, but after it enters inside the thorax, we have superior vena cava medially. Inside the thorax, after entering, we have superior vena cava. Okay, let's go back to our neck because all the important things have been covered. All of them are covered. So don't worry about it. Let's delete the veins. Let's delete the muscles too. We need to see the trachea. Okay. Let me show you some important things. This is our vertebral artery. This one is very important. Okay, this one is very important. Remember, this will be the first branch. This will be the first branch of subclavian artery, and vertebral artery will go up and enter our cervical vertebra. Which one? Number 6. It will enter number 6. Okay, it will enter inside number 6. Now, so foramen transversarium we can see. In this transverse process, we have a foramen and vertebral artery will enter through it. See, but we have seven cervical vertebrae. It's seven in number. Very simple. So what about C7? Guys, remember, C7 has a foramen, but vertebral artery does not enter that foramen. Vertebral artery does not enter. That foramen is blank foramen. That foramen is a blank foramen. See very carefully. See, there is no vertebral artery inside foramen transversarium of C7. Okay, C7, and it enters to C6. Okay, at this level, okay, here is our thyroid gland. Let me show you. Let me show you. Okay, this is our thyroid gland. Let me show you one thing. For that, we need to uh, then okay, then this is our vertebral artery, and this is our common carotid artery, and this is our external carotid artery. Common carotid, external carotid, internal carotid. Common carotid, external carotid, internal carotid. Common, external, internal. Okay. Internal inside the sheath. External carotid, it supplies all of the it supplies like all the blood supply to your neck is mainly from external carotid artery and face. Now, first branch of external carotid artery is this one, that is superior thyroid artery. They will ask you which one is the first branch of external carotid artery, superior thyroid artery. Now, why is that important? Because thyroidectomy is a very common operation. And during thyroid surgery, some hazards can happen. Thyroid cartilage, and we have cricoid cartilage under it. Anyway, in between thyroid and cricoid, we have cricothyroid membrane. Okay, guys, see, superior thyroid artery. Okay, and common. Let's hide the common carotid portion, and we have inferior thyroid artery coming from our thyrocervical trunk from subclavian. We don't need that. See, why do we need superior thyroid artery? Because during thyroidectomy we ligate this one, of course we ligate this one too, but during ligation of this one we can injure some structure, and they will ask you question from there. What are the structure? Will I tell you? No, I will show you. Okay, see, superior thyroid artery is very close to this structure, that is okay, as I have not told you about the nerves. See, vagus will give branches to larynx, and two branches, superior laryngeal and inferior laryngeal. Superior laryngeal and inferior laryngeal. Inferior laryngeal. Let's talk about superior laryngeal first. Superior laryngeal will come from above. This place is very small gap. Very small gap here. Okay. Superior laryngeal nerve will divide into two parts, internal laryngeal and external laryngeal. This is our superior thyroid artery coming from above, which is very close to superior laryngeal nerve. Superior laryngeal nerve gives two branches. One is external laryngeal and one is internal laryngeal. Remember, external laryngeal and internal laryngeal. See, external laryngeal is the closest to superior thyroid artery. So during ligation, most commonly injured nerve is this one. Second most common, this one, superior laryngeal nerve. Second. Now, what about inferior laryngeal nerve? Guys, see, vagus gives superior laryngeal nerve. Then vagus goes down, and it forgets that larynx is big and we need more nerve. for laryngeal muscles. So what do we do? Vagus returns and gives a recurrent laryngeal nerve, which is, because it's returns, that's why it's called recurrent laryngeal nerve, but it's basically inferior laryngeal nerve. So inferior laryngeal nerve is a recurrent laryngeal nerve. Very simple and easy. All of you know it. Still I just explain so you remember better. So so recurrent laryngeal nerve, RLN. Okay. Comes from vagus. Superior laryngeal nerve comes from vagus. And here we have superior thyroid artery. Let's say this one, superior thyroid artery. So if we ligate this structure, we can injure superior laryngeal nerve. We can injure external laryngeal nerve, and we can injure vagus too. This one. So we can injure vagus too. So vagus can be injured too. Very simple. Very simple. Now, from every nerve, if we take a cross section, let's say this is vagus, so it will have fibers for superior laryngeal nerve, it will have fibers from recurrent laryngeal nerve, it will have fibers for your abdomen and everything. When it's above, before giving the branch, right, it will have all the branches. And this can happen that during ligation you injure only some part of vagus, only some part of vagus. This can happen too. So this is just a point. Keep in mind. You will understand why am I saying it. Now, they will tell you that after thyroidectomy, a person cannot sing high notes. High notes. Why? When they say cannot sing high notes, remember it's external laryngeal nerve injury. Okay, it's external laryngeal nerve injury. So the clue is superior thyroid artery ligation and cannot sing high notes. We have it in our written note. Don't worry, I will show you. And if they say that after thyroidectomy, a person call you and you cannot recognize his voice, that means his voice is now hoarse. So hoarseness of voice. So hoarseness of voice is caused by recurrent laryngeal nerve injury. Why? I will tell you, don't worry. Recurrent laryngeal nerve injury, but we have ligated superior thyroid artery here and recurrent laryngeal nerve is here. Okay, recurrent laryngeal nerve is down. So what did we injure? We injured vagus, but only recurrent laryngeal nerve component, RLN component of vagus. Okay, you have to know the laryngeal muscles, and these are very tiny muscles and not possible to show it here. Still, I'm showing you a little bit, not so important. Just see. Okay, I can't. Okay, so this is our vestibular fold and this is our vocal fold. So vocal fold will produce sound. Okay, we have it better in our notes, so don't worry about it. Don't worry. Let me show you the other things you will be facing. You will be facing question from esophageal tumor and how. Let me show you. See, look at this place. This is our trachea, and these cartilages are C-shaped. These cartilages are C-shaped. That means behind we only have membrane. Only we have membrane behind, and in front we have cartilage. Okay, so this is soft. Cartilage is a little bit hard. You cannot compress it. So here we have our esophagus, and if we have a tumor behind, it will compress this membrane. membranous part, membrane like part, and it will cause your respiration problem. Very simple. It's pressing trachea and airway is obstructed. Airway is obstructed. So we will have problem with respiration. But only cricothyroid cartilage is a complete ring. Complete ring. Only cricothyroid is a complete ring. Let me show you. So if we have a tumor at this level, let's remove the muscles. Okay. And add esophagus. See, this is our cricoid cartilage and it is a complete ring. Let me show you from behind. See, this is a complete ring. This is a complete cartilage and others are just C-shaped. Okay, so if we have a tumor at this level, that will not cause problem in respiration. That will not cause problem in respiration. But after that, any tumor will compress trachea and you will have respiratory problems. So, so remember the vertebral level. Okay, this one C6. Okay, so cricoid cartilage is at C6. Okay, at this level, larynx become trachea, pharynx becomes esophagus, vertebral artery enters C6. So three very important informations. After C6, we have C7, we have T1, T2, T3. Remember, T4 up to T4. From C7 to T4, any tumor, any mass will compress trachea and cause respiration problem. And they ask you this question, that there is a tumor in T4 and will that person have respiratory problem? They will have this question directly. And at which level a person will not have respiratory problem? At C6, because we have cricoid cartilage and this is a complete ring. Other cartilages like thyroid cartilage, of course, thyroid cartilage, this one is not complete ring too. Where is our thyroid cartilage? Okay. No, I have removed thyroid cartilage. Let's not add it. So all the important things from head neck have been shown very clearly. Very clearly. Now we will go to our notes and tell you what to study from the notes.